So, okay, good morning, good afternoon, and good evening, everybody. Thank you for joining us for the second webinar in our series on climate change and health. And the topic of today's webinar is FETP, experience with heat exposure and the health effects of heat exposure. It is my great pleasure to introduce the moderator for today's session, Dr. Alden Henderson, who is from the CDC here in Atlanta. Dr. Henderson uses his academic training and professional experience to train public health professionals to identify unusual occurrences of disease and to identify the source and route of transmission of the disease so that actions can be taken to control its spread. He began his public health career in 1983 with the Hawaii State Department of Health, and in 1992 joined the Epidemic Intelligence Service at the Centers of Disease Control and Prevention. Over the next 30 years, he investigated outbreaks of toxic hepatitis in North Dakota, Rift Valley fever in Kenya, cholera in Vietnam, avian influenza in Thailand, Ebola in Sierra Leone, and of course, COVID-19 in the US. From 2008 to 2012, Dr. Henderson was posted in Thailand to train public health professionals in Southeast Asia on how to identify and control disease outbreaks and to establish field epi training programs in Cambodia, Laos, Singapore, Thailand, and Vietnam. He continues these efforts for Ministries of Health in Southeast Asia and African countries from CDC headquarters in Atlanta. Alden, welcome, and may I hand over to you, please.
Well, thank you, Carl, for that introduction. And I have a short presentation about heat-related illness. Could I please have my slides? Thank you. Next slide, please. So just to give a short overview of heat-related illnesses, this is the range of illnesses that can occur. Something as minor as sunburn and going all the way down to heat-related deaths. Next slide, please. The timing of this webinar is very good because actually in Atlanta, we are in the midst of a heat wave now. Next slide, please. And just a little trivia about heat waves. These are the top 10 heat waves with most fatalities. And if you look at them, most of them are in this century. Next slide, please. And as you notice, for heat waves, we often give what's called the dry bulb temperature. But I want to mention that there's something else called a wet bulb temperature, which is more appropriate because as it says here, the theoretical limit to human survival for more than a few hours in the shade, even with unlimited water, is a wet bulb temperature of 35 degrees C. Equivalent to a heat index of 70 degrees C. Next slide, please. So given this wet bulb temperature, and there's a critical part. When the wet bulb temperature is 35 degrees C or more, the body can no longer cool itself by sweating, and this will be fatal in a few hours. So all the countries in the world, there's 2 places that have passed that threshold. One in Pakistan and one in UAE. And unfortunately, in the next few years, we'll probably add to this list. Next slide, please. So now I want to bring this back to FETP. And basically, I want to say, what do we teach field epidemiologists to do? We count, compare, and communicate. So for each one of these, I will talk about what I have done with CDC and CDC FETP about heat-related illnesses. Next slide, please. So we'll start with counting. Next slide. So as epidemiologists, we have to be very good counters. So the first way of counting was just looking to see at deaths due to natural phenomena. And as you can see here, heat falls in number 2 after earthquakes. So looking at deaths in the last decade, heat waves actually caused the second most number of deaths due to natural phenomena. Next slide, please. Next slide, please. Thank you. So here's the Chicago heat wave in 1995, and we were mobilized to respond to this. And this is one of the most striking pictures where you see a line of ambulances, and this is not going to the emergency department, but actually going to the morgue, because there were so many deaths occurring during the heat wave and shortly afterwards. Next slide, please. So talking about counting, and we're looking to a case definition. So here was a case definition of a heat-related death. Body temperature of greater than 105 at the time or after death. The body was found in an environmental circumstances where there was no air conditioning, windows closed, or high temperature, or a decedent found in a decomposed condition without evidence of other cause of death who was last seen alive during the heat wave period. It seems obvious, but during this response, calling a person died from a heat wave was very controversial. Can I have the next slide, please? And it's actually, you could almost get a number you wanted by asking the right person. The numbers are all over the place, and it was very political as to what the actual number of deaths were. Next slide, please. Next slide, please. So given this, we got together with the medical examiners to put a position paper on what is a heat-related death. And next slide, please. So this is what we all came out with. It's quite more detailed, but still, there's a lot of professional that goes with deciding whether a death was heat-related or not, especially when you're not at the time of death. Next slide, please. So moving from counting to comparing. Next slide. So this is a paper we put out, and what I want to show here is, if you look at the proportional hazard mortality, so each of these pies represent the standard mortality ratio of deaths due to either flooding, geophysical, heat, drought, or lightning, and so forth. So the orange one is related to heat. And as you can see, just looking at this map, the heat-related deaths occur more in the north, and which is surprising because the hotter parts of the US are more in the south and the west. So this is one way that FETP epidemiology could help with heat illnesses, is just tracking the locations of where these events occur. Next slide. And this came from our response to the 1995 Chicago heat wave. This is quite a chart, but it tracks the number of deaths, the total number of deaths in Chicago in 3 categories. And if you look at the bars, the top is due to heat and cardiovascular. The orange one is due to cardiovascular alone, and the orange is due to heat alone. And as you see, looking at total deaths related to the heat index, the deaths actually occur after the heat, the peak of the heat. So the peak of deaths occurred after the peak of the heat index, and the proportion of each one due to heat or cardiovascular actually differed with heat mostly occurring earlier and then cardiovascular later. So this is something else we found that we call the hidden peril of heat waves, is that cardiovascular deaths kind of occur after the peak of the heat wave. Next slide, please. Besides deaths, you can also look at emergency department visits, and one of our speakers here will be talking about that later. Next slide, please. Next, and the last one is about communication. Next slide, please. Sorry. So this is another study we did. Heat waves seem to happen in Chicago, and we were there, and we did a typical epidemiology study, which involved looking at the deaths and doing a case control study that we usually do. And looking at conclusions, it was quite obvious that, of course, a working air conditioner is the strongest protective factor. But we also found other things that was more interesting. And then, as you see at the bottom here in the conclusions, social isolation and advanced age remain important risk factors. And this was very kind of astounding to us, being epidemiologists and looking more at heart conditions like air temperature and things, but more of a behavior part came in. And can I have the next slide, please? So given this, several years later, Eric Kleinberg, who is a social scientist, came out with this book on heat wave, and it's called A Social Autopsy of the Disaster in Chicago. And this was his version of his study about the heat wave. And I read this book, and it's a very interesting way of looking at this event through the eyes of an anthropologist. He basically came out with the same risk factors as we did, but he delved in a bit deeper of why this happened. So it was very interesting view of an investigation that we did as epidemiologists, and now we have a social scientist look at it. And I would encourage us as epidemiologists to include these social sciences when we do investigations. They have a very interesting viewpoint, and it's very refreshing. Next slide, please. And the last thing about communication is CDC now has this heat and health tracker, and it kind of shows the United States in different colors, a heat map they call it. And as you can see, we have a lot of heat down in the south, and the circles represent emergent visits to the emergency department. And next slide. And on top here, the three rectangles shows you the latest information of number of deaths, emergency visits, and hospitalizations. Next slide, please. Next slide, please. And that's the end of my brief talk and introduction to heat illnesses, heat deaths, and FETP and EIS getting involved in responses about counting, comparing, and communicating our findings. And now we have our first speaker, Dr. Kumar. He holds a BBS and an MD in community medicine from Chandigarh. And after that, he did teaching for 1.5 years. This was followed by a 2-year training in the India Epidemic Intelligence Services program. Then he worked for 2.5 years in the National Program on Climate Change and Human Health. Human Health and Family Welfare in Delhi, India. Currently, he is a district epidemiologist in Mohali in Punjab state, and his talk is about a national plan on heat-related illnesses. You have the floor now, Dr. Kumar.
Thank you, Dr. Alden. Am I audible?
Yes, we can hear you very well.
Yes, thank you. Thank you very much for the introduction. Can you present the slide? Yes. Good morning, good afternoon, and good evening to all the participants. And thank you for inviting me to present the National Action Plan on heat-related illnesses. The link for this action plan is the first slide itself. You can download it from there, and I will be presenting it in the brief during the presentation. So next slide, please. So India is among the highly vulnerable countries due to its geographic and demographic presentation, as already told by Dr. Alden. And it was the 7th most climate affected country in 2021, according to the Global Climate Risk Index 2021. And the frequency, intensity, and extent of heat wave is estimated to be increasing. And there were estimated 8 deaths per million extreme environmental temperature in 2019. And it is expected by 2100 that around 1.5 million excess deaths per year will be there due to climate change, especially heat stress. So heat waves is projected to be next big killer after COVID-19, as per UN report 2022. Next slide, please. So before I start further presentation, I would like to say that not only Ministry of Health, that is Health Department, is not involving in this. Not only the ministry involving in managing the heat wave, there are other departments, and I must say that the National Disaster Management Authority is the first one among us who started this initiative to manage the heat wave impact in the country. And for that, they prepared the guidelines. So the other states can prepare their heat action plan. So which department has to do what, their roles and responsibility, what should be there. That was in their guidelines to prepare the heat action plan. So according to that, we acted while I was in this national program on climate change and human health, and we prepared this health specific heat action plan. So as you already know, so other department obviously is the Indian Meteorological Department. They provide the data about the heat waves, in which area is heat wave prone area. So they provide the current and forecast weather information to us and to all the states and districts. And next is our department, that we prepare the action plan that we have mentioned. And previous to that, we have already prepared the guidelines on prevention and management of heat-related illnesses. That was specifically for the physicians dealing with the cases in the hospital. So that was prepared earlier for this section plan. And we were doing the surveillance on heat-related illnesses since 2015. That I will be elaborating on it in further slide. And other department is at the state level, the state disaster management authority, that they prepare their state specific heat action plan. Next slide, please. So to prepare our health sector specific heat action plan, we get in touch with the other experts that were already dealing with this heat wave. So we invited them all for our expert committee, and we took their all the suggestions, their inputs, and we communicated several occasions to make these guidelines came into the picture. And these guidelines was released by our health minister in July this year itself. Last year in 2021. So the expert members were from the National Disaster Management Authority, National Institute of Disaster Management, in India Meteorological Department, and then we have in ourselves several other departments who look after this. There is integrated disease surveillance program that is doing the surveillance of many diseases. Then our program division was there, national program on climate change and human health. Then there is a disaster management and emergency medical relief department. And we invited the specialists from medicine branch, pediatricians, and the community medicine. We invited the experts from Indian Institute of Public Health, Gandhinagar. And I must say that even before the NDMA, they were engaged in doing this activity of counting, comparing, communicating the data about the heat-related illnesses. And then further is the Public Health Foundation of India that is located in the Hyderabad, and expert from the World Health Organization. Next slide, please. So this is the table of content that I have taken a screenshot, and in further slides as well, there will be a screenshot of this action plan. So, so basically it starts with introducing what is heat-related illnesses, what is heat wave, and then the clinical manifestation and summary of spectrum of heat-related illnesses, and what workup, like what investigation they have to do for this heat stroke. And then we have the management workflow. We have the specific management plan for pediatric age group. And then there is hospital preparedness plan, what hospital has to do, what they have to prepare for before the heat wave season, during heat wave season, and after heat wave season, what they have to do, that is in there. And then there is a guidelines for investigation of suspected heat-related illnesses that has already been told by Dr. Allen that there is difficulty in doing this investigation. So we have prepared the guidelines how to investigate, because there is no gold standard diagnosis for heat stroke. So in what way we have to do, we have mentioned that in the guidelines. And then we have the surveillance of heat illnesses, that is especially if we have to know the extent of disease, we have to establish a surveillance system. So my main focus will be on this, how we establish this surveillance system, and how we in between change that the method of counting and the further things we will be discussing in the further slides. Next slide, please. So as I already told, the heat includes heat syncope, muscle cramp, heat stroke, heat exhaustion, and further life-threatening emergencies such as heat stroke. And there are further other like heat edema and heat tetany as well. And so in India, heat wave is considered if the maximum temperature of a station reaches as 40 degrees Celsius or more for plain reasons, and 37 degrees Celsius or more for coastal station, and at least 30 degrees Celsius or more for hilly region. And the further is the following criteria is used to declare heat wave. So above is the heat wave, but if we have to declare by the IMD department, this is the criteria that based on the departure from the normal, that is the average normal of that region. If it is departure is more than 4.5 degrees Celsius to 6.4, it is heat wave, and it is if it is more than 6.4, it is severe heat wave. And based on the actual maximum temperature, that is if it is for the day, and it is especially only for the plain region. So if actual maximum temperature reaches more than 45 degrees Celsius, it is heat wave, and if it is reaches more than 47 degrees Celsius, it is severe heat wave. Next slide, please. So these are the we have enlisted the diseases and mentioned about their symptoms and then signs, and what workup we have to do, ranging from ABC, artery blood gas, random blood sugar, serum electrolyte, LFT, coagulogram, everything. So we have mentioned all those things in the guidelines. Next slide, please. Then there is management flow. So there is at the primary level what they can do, and meanwhile they are referring the patient to the tertiary level, what they can do to manage the patient, and at the tertiary level what physician is expected to do, that is mentioned in the flow chart at the tertiary level. Next slide. So for children's, we have given the guidelines on what is how we have to manage the case at the emergency level, emergency department, and if the children is engaged in the sports activity, what guidelines they have to follow, and first aid instruction for the teachers, or you can say sports teacher, if child is found to be having heat exhaustion or heat stroke. So that is all in there in the guidelines. Next slide. So this is the clinical flow that we have mentioned for the physician, for the pediatrician treating the child in the hospital, and all the things have been mentioned specifically, and by taking the ideas from the inputs from the tradition from the expert community. Next slide, please. So there is guidelines for children going for sports activity during summer season. We have for initial level, we have to do the screening for any health condition or any medication that he or she is taking and is suffering from any fever or any other illnesses. And then we have mentioned that they have to be acclimatized, at least increase the activity should be increased over 1 to 2 weeks. Their athletic gear or garb should be light color, lightweight, loose, and sweat wicking, and they should be properly hydrated before, during, and after. The sports activity can be scheduled in the morning or the evening, and for the preparation, they should have a medical equipment out there. Any action plan should be there. Next slide. So this is the first instruction that they can paste in their gallery or in the specific area that they can paste, and in the form of pamphlet or poster they can distribute or paste in the gallery and other areas. So we have mentioned that is instruction for teachers as well and for the parents as well. So what first aid that they can give. Next slide. So we have the hospital preparedness plan, as I mentioned, that we have pre-heat season, what they have to do at the hospital level, what the medical superintendent of the hospital can, what kind of plans that they should have, ranging from the infrastructure, logistics, capacity building, and the information, education, communication, IC activity like awareness activity. At the PSC, the primary care health, primary health center level, the community health center level, at the district level. This is the primary, secondary, and tertiary level that it is PSC, CSC, and district hospital. So we have given them the framework on the basis of which they can take the activity that they have done, what they have to do. So that is all in there. Next slide. So this is the screenshot of those activity that they can look after, that what they have to do and what they have to prepare for. Next slide. So next is the heat-related illnesses surveillance. As already mentioned, that to know the extent of disease and to communicate that to the policymaker and to the public as well, and to know how much it is affecting our community, we have to do the surveillance, and we have to establish the surveillance and establishing services. And I think evaluation of any service system is a part of FETP program that I have done. I did that during my training period, so I know that there is those things that we have to look after: the simplicity, usefulness, and the representativeness, and acceptability. All those things we have to look after. So while we were looking after that service system, I evaluated that, and there were my colleague was there who evaluated that surveillance system, and we found that some the things the surveillance should be changed. So that the surveillance system on which they were the format on which they were taking this data, they were taking the data on number of heat illnesses cases that were occurring at the PSC, CHC, primary, secondary, and tertiary level, the number of suspected and confirmed heat related in this death. Those are the simple things that they were taking. And so we can say, looking after this two factors, we can say that that was simple. But we revised that based on finding that if we take only heat illness cases, that include ranging from heat rash, heat cramps, heat exhaustion, heat stroke, and heat edema, all those things that include that. So that segregation was not that we don't know at the national level, the state or district, the data that they were sending, what was that? If the cases, like in Kerala state, they were sending 1,000 number of cases, and Telangana only sending only 50 number of cases during the season. So while evaluating that data, we found that those cases at the Kerala level, those were maximum for the sunburn, and sunburn is a minor illnesses. And for a surveillance system should be that it should be feasible to at the time level, that the data should be the thing that we are getting from that field level, that we should be able to do anything for them. And if the data is for heat rash, and we will get in those things that we have to manage all the heat rash, though, so our health system will get collapsed, because we can't manage all those cases. We have to focus on those cases that is affecting the causing the mortality. So basically, so we changed those guidelines, and we included only the heat stroke cases. So now we are sure that the cases that are coming only include heat stroke, and heat stroke is a very severe condition. Next is included that we included, no, not the slide, previous slide. So that thing we change as well is that the suspected and confirmed heat stroke death. So as I already mentioned, that the diagnosis of this heat illness death is very difficult. So, and we have in the previous webinar that we have mentioned that during heat wave season, all the deaths increases, whether it is due to the cardiac or respiratory and kidney problem, those death increases. So we included on all cause death column in that form. And so now next slide, please. So for comparison, I have given the both formats, and our format is only heat illness, and the below column it is here heat stroke. Next slide. Next slide, please. So we gave them the case definition as well. Earlier there was they have to get the only heat illnesses cases, so there was no specific definition. So we gave them definition for heat stroke. We gave them two definitions. One is for included the body temperature. You can see that we have to take the temperature more than 40 degrees Celsius or more than 104 degree Fahrenheit. But at the primary level, I can say in the India, in the the availability of thermometer is also, you can say, not there. So we included the clinical definition as well, that we changed that definition with the hot and dry skin, that body is hot and the skin is dry, that as well is considered as a heat stroke, because other condition are also met, that there is altered mental sensorium and with hot and dry skin and deranged vital. And in the epidemiology training, we know that this how important the case definition is. It should be simple and but includes all the things that we have wanted to include. Next slide. So this is the surveillance system, how it works from the primary to the tertiary level. Next slide. And we also gave them guidelines how to analyze. So we know that data is only is helpful if it is analyzed, and if from the analysis, if we make any conclusion, that is also useful. Only getting the data is not the thing. So for that, the district level, it is they don't have those skill how to do that. So we gave them step by step how to do that. As you can see the screenshot, that from where to find this option that was also there, and how to prepare the maps. That is a simple map, not the spot map that we usually prepare. But the simple thing is that that the block level, below district level, block level, how to prepare those things and how to make that graph. We have mentioned that in the guidelines. Next slide. And lastly is the guidelines on how to investigate the suspected heat-related death. So death due to heat, we already know that there is no gold standard test or procedure that can confirm that the death is due to the heat stroke. And during that season, respiratory and cardiovascular deaths increases. There are electrolyte disorders and kidney problems get worsened during the heat wave. And though the diagnosis of heat wave, death due to heat wave usually usually don't occur. The diagnosis is usually mainly cardiovascular, respiratory. So that heat death gets skipped. So we have mentioned that. So based on that, we have made those guidelines on how to come to the conclusion by seeing the circumstances in which the death occur. We can say the medical officer can conclude that yes, this death was probably due to the heat stroke. So there is a standard that the standards formalized for the doctors or the acknowledged as they are the part of the investigation team. I think I mentioned here that there is an investigation team that investigation any death at the village level or the block level. That includes even the police, from the person from the police department, officer from the police department, and from the there is emergency relief revenue department, and from the health department. So these are the three members of the committee who give the final say on that was whether due to the heat or not, because there is a compensation is given for any death that occurred due to the heat, because it comes under the Disaster Act in few states. So that was specifically, so from the health point of view, we consider that if any doctor is part of the team, they should know how to give the specific their decision based on the triangulation of the things that have occurred during that period. So the formats will give more option to get a better understanding that the death is due to the heat-related analysis or not. So there is a section that I have mentioned, and that is include the disease and details, their death details, their clinical history in past 24 hours before the death, their outdoor activity just before onset of illness, their indoor condition just before the onset of illness, past medical condition, weather data from the IMD. So the screenshot, I have not included that in the slide. So can I present that? Okay. So I can say that here what is there in the guidelines, that the clinical history in past 24 hours, we will ask about any medical condition because due to some medication, it can look like that it is due to the heat, but if it is on medication, we can exclude that thing occurred due to that the medication that he had. And outdoor activity, like if a person is a farmer or a laborer that is working outdoor, so we can conclude that yes, he was working outdoor for so many hours. That's why he might have got the heat stroke. And indoor condition, like the fan was working or not, was the indoor condition was if there was any AC or cooler was there or not. If not, and the temperature of that day based on the weather data from the MD of if the weather was or the heat wave did occur on that day, then we can conclude that yes, it might have occurred due to the heat related heat stroke. So next further slides are basically awareness material that we have prepared. Next slide. Next slide. So this is in the Hindi language or Indian language, and the English language we have prepared do's and don'ts. Next slide. For children's we have prepared. These are the comprehensive one, and we have asked the states to prepare more specific one as well. These are the that include, you can see that is a comprehensive one, and you can segregate all the things to make it more larger one. Next slide. And the symptoms we have mentioned in the IEC. Next. For the workers who are working outdoor in the heat condition, how they can save themselves during this heat condition. Next slide. Yeah, and this is as well for the workers. Next slide. Thank you.
So thank you, Dr. Kumar, for that extensive heat plan developed by India. And so our next speaker will talk about surveillance. Once again, very important for knowing how many people are ill. Our next speaker is Christopher Wittook. Christopher is a first-year field epidemiologist with the Public Health Agency of Canada's Canadian Field Epidemiology Program. Christopher is currently placed at Vancouver Coastal Health, which is a local health authority in the province of British Columbia. He is a registered nurse and holds a Master's of Science in Epidemiology from the London School of Hygiene and Tropical Medicine. His FETP work is focused on communicable disease surveillance, including sexually transmitted and blood-borne pathogens and COVID-19. He also provides support to other portfolios, including harm reduction and environmental health. Then, as part of his body of work, he will be presenting an evaluation of an emergency department-based heat-related illness surveillance system. So Christopher's presentation is entitled Evaluation of an Emergency Department-Based Heat-Related Illness Surveillance System. The floor is yours, Chris. Thank you.
Thanks so much for the kind introduction, Dr. Henderson. Yeah, if we can bring up the slides, that would be great. Perfect. So as described, I'll be presenting today on an evaluation of an ED-based heat-related illness surveillance system. Go next slide. And if you just hit next one more time, I'm just going to provide some context. So British Columbia here is on the west coast of Canada, and due to the presence of mountain ranges in the Pacific Ocean, its climate varies pretty significantly from one region to another. And next. And you'll see BC is highlighted in the red box there just to frame this work. And next, please. So a little background about Vancouver Coastal Health. This is the local health authority in which this evaluation took place. It's one of five geographic-based local health authorities within BC. VCH is home to 1.25 million people. So this is about a quarter of the BC population, and it's comprised of both urban and rural areas. Due to its coastal positioning, VCH experiences a pretty moderate climate. Daytime highs in the summer average around 20 degrees Celsius, which is quite a bit cooler than other areas in Canada. And due to this, most homes in coastal BC do not have any type of air conditioning, which is an important point. And next, please. So globally, heat extremes are increasing in frequency and intensity, and this trend is expected to continue. Doctors Henderson and Kumar described heat-related illness really well, so I'm not going to go too far into that, but one of the main points for this presentation is that depending on severity of heat-related illness, individuals may require emergency department or ED level care. So last year in 2021, between June 25th and July 1st, BC experienced a period of extreme heat, which was referred to as the heat dome. And unfortunately, this event resulted in over 600 deaths across the province. So it was quite significant. In response to and leading up to this extreme heat event, Vancouver Coastal Health rapidly built a surveillance system, which is based off of existing ED surveillance processes to capture and characterize heat-related ED visits within the health authority. Next, please. So the purpose of this surveillance system was to monitor the health impacts of extreme heat events within VCH, with the ultimate goal of providing situational awareness and to inform interventions. The objectives of the system included providing timely and actionable data to promote early intervention, monitor for geographic, demographic, and temporal trends to characterize the short-term impacts, and also provide insight into future heat events. And finally, to monitor for trends in clinical presentation, acuity, and outcomes. Next, please. So this is a very simplified data flow diagram describing how data moves from arrival at emergency departments all the way to dissemination to stakeholders. If you just hit next, please. I'm just going to focus your attention primarily on the areas in green, as there's two components to the surveillance system. One is weather data and one is emergency department data. The evaluation focused solely on emergency department data. So if you hit next, please. So to start, ED visit details are entered into electronic medical records within VCH hospitals, and this information is stored in two data systems depending on the hospital. So for context, within VCH, there are 13 EDs that are run by Vancouver Coastal Health, and at the time of this evaluation, data was available for 9 of those hospitals. Next, please. And one more time. So the data is then received by the Public Health Surveillance Unit, which is then analyzed to classify these visits into heat-related visits or non-heat-related visits. And next. So this algorithm is described here in summary. So basically, what it's doing is looking at the raw ED data, looking at primary presenting complaint. So the reason why someone showed up in ED, the primary discharge diagnosis that was applied during that visit, and the associated ICD-10 code. And once this analysis is complete, if you don't mind hitting next, that would be great. And one more time. Oh, and maybe one more time, sorry. Once the analysis is complete, it's exported to local storage and to a remote dashboard server. So this dashboard server feeds up to an internal dashboard, which is then displayed to various stakeholders. Next, please. And one more time. Thanks. And the stakeholders within Vancouver Coastal Health include the medical health officers, which help drive interventions, as well as the environmental health department overall. The goal of which is to increase situational awareness, to respond to and inform municipalities to actually roll out most of the interventions here in BC. And next, please. Perfect, thanks. So this is an example of Vancouver Coastal Health's heat surveillance dashboard. So this is what would be looked at internally. I've added some data in here. It's all fabricated just for your reference. So as you can see, this dashboard characterizes heat-related ED visits by person, place, and time, as well. It incorporates recorded and forecasted weather data for contextualization and situational awareness. So you can see a bit of an epi curve right in the center, as well as a line graph just above that, which shows recorded high and low temperatures from various weather stations throughout the region, as well as historical averages. This product allows for stakeholders and decision makers to glean a pretty high level situational awareness, or if the need's present, to obtain more granular information on those who are impacted within our health authority. It's also a nice example of marrying health and environmental data for greater understanding of the heat events and their associated health impacts. Next, please. So moving on to the evaluation, the triggers for this evaluation included the following. Due to the system being built very quickly during an unprecedented heat event in VCH, it was important to evaluate the system to ensure it was meeting its objectives. Similarly, we anticipate future heat events, so optimizing performance of the system is very important. And finally, we hope to use the results of this evaluation to inform the environmental health surveillance portfolio more broadly. Next, please. So 3 attributes were chosen for this evaluation based. Oh, sorry, I think I was muted. Apologies. For this evaluation, 3 attributes were.
You keep going on mute, Chris. Hang on one second. I just want to make sure, are any of our panelists accidentally muting Chris? And if so, try to refrain from doing that.
Thank you.
Go ahead.
I think we're good. Okay. So for this evaluation, 3 attributes were chosen based on the CDC guidelines for evaluating public health surveillance systems. The objectives for evaluating each attribute are as follows. So we looked at timeliness, and we aim to understand potential time lags, which may then impact timely situational awareness of heat events. We looked at sensitivity, specificity, positive and negative predictive values in order to assess the ability of the algorithm to correctly classify the heat-related nature of the ED visits. And finally, we looked at flexibility to assess potential integration of new data sources to enhance our understanding of who's impacted, as well as the flexibility of the system to adapt to evolving reporting needs. Next, please. So in terms of methods, for timeliness, our goal is really to assess the time lag between arrival in emergency departments and data availability to the public health surveillance unit for analysis. So for this, we picked a 1-week period from June 25th to July 2nd, which aligned with our heat wave of 2021. And we stratified this analysis by visit type, meaning heat-related visits only compared to all visits overall, as well as the day of week on which the visits occurred. Next, please. In terms of evaluating sensitivity, specificity, positive and negative predictive values, we conducted a chart review, which we considered the gold standard to which we compared our algorithm results. So this chart review consisted of looking at 500 ED visits on a single day, so June 28th, 2021, which was the peak day for ED visits during the heat wave. We weighted our sample by hospital visit volume to ensure representativeness across the health authority. In terms of the actual process, we looked at electronic charts. They were reviewed by myself and a medical resident, and we were both blinded to the algorithm classification. Our scope was limited to classic heat-related presentations. So by this, I mean, heat exhaustion, heat stroke. We excluded, chronic conditions such as cardiovascular disease that might be exacerbated by heat, as our algorithm was really focused on those classic presentations. We also picked a subsample of about 15% of charts and double-coded them throughout the process and measured intercoder reliability to ensure consistency in our approach. Next slide. And finally, the methods for flexibility, the system generally, because it's so new, it hasn't had the opportunity to adapt to new data sources or focuses. So we took a pretty prospective approach to this attribute. Based on public health surveillance unit priorities, various data sources and an additional climate-related health impact focus, so cold-related ED visits, were assessed for hypothetical integration into our existing surveillance system. So in order to do this, we looked at various criteria, such as whether the public health surveillance unit had current access to the data source, whether we were familiar and used the data source regularly, how easy it would be to integrate these data sources into our existing dashboard products, as well as effort needed related to additional coding. I interviewed key informants from the public health surveillance unit to obtain their perceptions of flexibility as well. So next slide. So moving into results. This is looking at timeliness for all ED visits during the 1 week period. So this is about 10,000 visits across the health authority. The average lag time between arrival and emerge and data availability was 35 hours with an interquartile range of 36 hours. So this particular figure is really interesting because it displays the time lag between visit arrival and data availability by day of week on which the visits occurred. So what you'll see here is, it's pretty interesting. Sunday, Monday, Tuesday, and Thursday had low lag time with median lags between 17 to 19 hours. Wednesday and Saturday had a higher lag time with a median of just about 40 hours. And Friday had the longest lag time with a median of just over 60 hours. So interestingly, this particular week that we looked at, July 1st, the Thursday there, was a holiday. So with that in mind, we realized that we didn't receive routine data on holidays and weekends, which contributed to increased delay times. So within the sample, for example, data for those who visited ED on Wednesday was not available on Thursday, where we would normally expect to receive it, and actually arrived on Friday morning, which increased our midweek time lag. Similarly, data for those who visited ED on Friday would not be available to the following Monday. Next slide, please. So zooming in a little bit, this shows timeliness for those visits who are identified as heat-related by our algorithm during that 1 week period. So this equated to 254 visits. The average time lag was 29 hours with an interquartile range of about 15. So a little bit lower than all heat-related visits. But what you'll notice here is the similar pattern by day. So Sunday, Monday, Tuesday, and Thursday having lower lag times than Wednesday, Friday, and Saturday. In investigating why there was a bit lower lag time in these heat-related visits, what we determined were the majority of these visits actually occurred on Sunday, Monday, Tuesday, just due to the nature of when the heat event occurred, which lowered the average lag time. Okay, next slide. Moving on to results for sensitivity, specificity, positive and negative predictive values. What we found here, and I've got a contingency table comparing our algorithm results versus our chart review results. Our sensitivity was a bit lower than we were anticipating at 59%, which reflects room for improvement related to identifying all heat-related cases. You'll note here that there were 27 visits that were not identified as heat-related by our algorithm, but were picked up on our chart review. On the other hand, our specificity was quite high at 100%, meaning that all non-heat related visits were correctly identified. Our positive predictive value was also at 100%, so those identified as heat related visits were done so correctly. And our negative predictive value was 93%, so basically meaning most of those visits were identified as not heat related were done so correctly. Keeping in mind here too that the positive and negative predictive values were calculated during a period of relatively high prevalence. Okay, next slide. And finally, so we have results for flexibility here. So what we did, we took all these potential data sources that we're interested in integrating, as well as our additional focus of the surveillance system, and we classified these into varying levels of flexibility, so low, medium, and high. So in summary, our system had low flexibility to integrate comorbidity data due to the lack of current data access and familiarity with the data fields, as well as potential for high workload related to coding, depending on the data source that's chosen for integration. Our system had medium flexibility to integrate outstanding rural ED data. So we're currently missing 3 of 7 rural ED rural hospitals due to data infrastructure limitations. We also had medium flexibility for integrating pediatric ED data and mortality data due to lack of current access and familiarity with the source. The system, on the other hand, had high flexibility to integrate emergency health services data, a deprivation index, which was actually just completed a couple of weeks ago, and a shift in focus to cold-related ED visits as our data access is either in place or more easily obtained, as well as the public health surveillance unit is familiar with these data sources, and there is relatively light coding requirements. Okay, next slide. Okay, so overall, the system was quite timely. However, timeliness could be improved through exploration of receiving our ED data on holidays and weekends, as well as pairing this with automation of our algorithm to ensure that our dashboard is updated on the days where there might not be surveillance staff working. Our sensitivity could be improved through adapting our heat-related algorithm to incorporate secondary and tertiary presenting complaints, discharge diagnosis, and ICD-10 codes to ensure all available documentation is captured, as it currently only looks at the primary presenting complaint, primary discharge diagnosis. In addition, we could consider monitoring for non-classic heat-related presentations and diagnoses to capture potential heat-related visits that were not documented as such. So by that I mean, exacerbations of chronic conditions and other situations like that. And then finally, in terms of flexibility, data access remains probably the biggest barrier for flexibility of our system. So continuing the ongoing work to explore data sharing agreements would be helpful for the Vancouver Coastal Health. So overall, these results will allow for enhancement of the ability of the public health surveillance unit to characterize the impact of heat-related events on the VCH population with the underlying goal of driving interventions. And next slide. And finally, I just want to provide a couple final reflections from a field Epi perspective. What really stood out to me through this evaluation was that Vancouver Coastal Health really leveraged and pivoted existing surveillance infrastructure to focus on heat-related illness. This allowed for VCH to rapidly obtain great situational awareness during a very unprecedented heat event. So a key learning from my perspective is that it's important to take stock of what resources already exist that could be leveraged to increase our understanding of the public health impact of climate-related events. Examining and utilizing local surveillance systems and potential supplementary data sources, such as weather data, can support climate-related health impact response efforts. Okay, next slide. Okay, to finish off, I just want to provide acknowledgements to the big team at Vancouver Coastal Health who supported this work greatly, as well as the Public Health Agency of Canada and the Canadian Red Cross for external review of the protocol. And yeah, that concludes my presentation. So thanks so much for your time and happy to answer questions.
Okay, thank you, Chris and Dr. Kumar, for your presentations. And we are open for questions and answers. We have 3 questions in the Q&A box. So I'll read the first one. It says, thank you for this important work and interesting presentation. How is the normal temperature for an area calculated when declaring a heat wave? Does this calculation take into account more recent historical temperatures? And how does it take into account abnormalities like past heat waves? Dr. Kumar, could you answer this, please? Thank you.
Basically, for declaring the heat wave, the criteria is given by the Indian Meteorological Department, and I think they are best here to answer that. But as far as I know, they take the average of the past temperature. I think it is more than 50 or 60 years, the temperature for that region. If it is, they think that for that day, I think for the 1st June, if the temperature remain at the average of 40 degrees Celsius, they consider it normal for that region. Yeah, and if it raises by a few temperature, then it is considered that yeah, temperature is deviating. That is basically for the temperature that is deviating. But for the heat wave, that basically they have done a study at the various level, because you have already mentioned that it is based on the how the human felt the heat. in India, even there are different regions. Like in Rajasthan region, even people don't feel any. They feel heat at around 45 degrees, but they have adapted for that temperature. So that's why that for different reasons there is a heat wave is different for those people. So based on that thing, they have different kind of calculation that they have made, and based on that criteria they have given that and they have made that guidelines.
Okay, thank you. The next question is for Chris. They're curious, how high were the temperatures during the heat dome?
That's a good question. I was just pulling up our dashboard to take a look, and you know, there's kind of a few things that are important. I think during that particular heat dome of last year, you know, the daily high temperature looked like within VCH at one weather station was 32 degrees. The nighttime high during that same period was 20 degrees. One thing that was really interesting and actually, you know, increased the impact of heat-related health impacts during that heat wave was the internal temperature. So the indoor temperature. You know, we found that a lot of the deaths that happened within VCH occurred indoors, where the temperature is actually much higher than the ambient temperature outdoors. You know, in some cases exceeding 40 degrees Celsius indoors. So you know, considering both is really important. The data source that we have monitors external temperature, but indoor cooling is very important for sure.
Yeah, thank you. Another question I guess this is for Chris again. What approaches is advised if no monitoring is in place? What steps should be considered when starting monitoring and providing data statistics considering health and health-related illnesses?
Yeah, that's a good question. I mean, this particular system was really well established and based on existing ED surveillance. So it required just a very few tweaks in terms of adjusting our coding to capture, you know, well-defined diagnoses and well-defined ICD codes. So that was a facilitator for us adapting so quickly. I think, you know, in terms of monitoring when no system is currently present, I think having consistency in your approach, very clear case definitions and what you're considering a heat-related health impact is important. And I know Dr. Kumar touched on sometimes how that can be difficult, and you know, I think Dr. Kumar's work explained surveillance in various settings as well. So I don't know if he may have an additional comment, but consistency and clarity in what you're measuring and measuring it consistently over time would be something I'd consider.
Hi, Dr. Kumar, any additional comments to that question?
Yeah, so I think to capture the data, to have know about the illnesses, we have to have a system there. So if anyone is giving you an information, that is basically an system that has been there. So I think we have to establish a system and no other way that we can.
Okay, thank you. Another question for Chris. Did VCH already have an ED data flow set up before the heat wave? And then besides heat-related illness, what else is it used for?
Yeah, thanks, Janice. I think, I mean, absolutely. There has been existing ED surveillance occurring in VCH since Vancouver had the Olympics hosted here. It was set up in response to that, I believe. And you know, it monitors for many different kind of syndromic conditions. It monitors for injuries. It's used in many different portfolio areas, such as overdose response. So it was really just adapting a tool that was quite well conceptualized and set up. Yeah.
Okay, great. Another question for Chris.
I can come again.
Thank you.
Again, that I would like to add something, that the difficulty that we have faced, and but the thing should be there, that for establishing service system like that, because first we have to say that we already have many system to capture the data, and already there is integrated disease surveillance system that I have already mentioned. And if we want to get the more information like this heatliness additional data, we are asking at the field level, that become very cumbersome for the field level, that we have to do the counting of new disease as well. So the thing that we should consider while establishing a system is that it should be simple, that like I've already mentioned that earlier it was heat analysis that encompasses heat stress to heat cramps to heat exhaustion to heat stroke. But we focused only on one thing, that heat stroke should be there because it causes the mortality, and we should focus on the thing that affect the public health. So we should focus on those things that is affecting, because if we capture the data and we give that data back to after analyzing and communicating that data to the public and policy maker, that can be in the eye opener to them, that the system should be there and the thing should be there, and after that they will accept that system. So first thing is that the simplicity should be there, as much as simple should be there to start a system, and then further you can add on as you wish.
Thank you. Thank you, Dr. Kumar. Next question is for Chris. Says, it is a testament to the health system to so quickly adapt to such an unprecedented circumstance that was relatively short-lived. Had previous years been trending in such a way that allowed them some level of preparation?
Yeah, that's a good question. To my knowledge, I mean, I arrived in BC last year, so I don't have too much historical background. But I believe the 2021 season was definitely unprecedented for the region. You know, I don't think we ever saw that level of ED-related or heat-related ED visits in the region, and certainly the level of mortality in the province was quite extensive. I believe that you know, during that 1 week period, they're looking at the BC Coroner's report from last year, and I think typically during that 1 week period, there were around 200 deaths that were investigated, and last year there was 800 deaths that were investigated, resulting in 600 that were attributed to heat, so or approximately 600. So yeah, it was absolutely unprecedented, and I don't know if there was much historical trend to you know, promote quick response.
I have a question for Dr. Kumar. Regarding counting the deaths, in Chicago, people who died at home were sent to the morgue, so we could actually have a good counting of people who died during the heat wave. I know in other countries, you don't have such facilities. I mean, how do you ensure that the number of deaths is accurate in a place like India? Over.
Yeah, so the number of deaths, if you are saying that the figure usually is not being shared at the higher level, and the political consideration is there, you have already mentioned in your slide as well, and that thing is also there, and yeah, I can say that thing is there, and whenever we establish a service system, if we include a column of the death, you can say that we are giving the death to the surveillance system itself. So we have to initially start with only the cases, and whenever that suspected death, what happened to that case, we inquire about that. If that die, then they have to answer that thing. So when they give that answer, then we ask them to go give that thing in the format itself, because that what happened to that suspected heat stroke, was it is it still admit or not? So we have to keep on asking them about that thing. So as I've already mentioned, we have to go step by step. We have to start with a simpler thing, that they have to give only the count, and then further we have to give a count of the cases. Then further we ask about the death. So in that way, when the system is established that there is no way that we can hide that, they have to give the number of deaths, because there are other ways in which by way we can find out that the death are increasing in that region. So yeah, initially it is difficult, but in coming days it become a regular thing.
Thank you. Another question for you, Dr. Kumar. It says here, at the start of your presentation, you stated that heat waves are projected to be the next big killer after COVID-19. Given this rather jarring fact, how do you think that public health professionals and field epidemiologists in particular can work to ensure they have the training and skills needed to respond to issues related to extreme heat? Hi, Dr. Kumar, you're on mute right now if you're trying to answer.
Yeah, can I have a question again?
Sure. You mentioned earlier that COVID-19 was a big killer and that you expect heat to be the next big killer. So how can we as field epidemiologists prepare for that? What kind of training and skills are needed? Over.
So there in where we have the national program on climate change and human health. So earlier in India, there was a climate change program. You see, there was climate change program under which there were 8 missions, and that included only from the transport or forest and all those departments. The health mission was not there. You see, so only in 2008 that health mission was included. Sorry, I think it was in 2014 or 15, the health mission was included. So earlier there was only climate change, and health mission was included in 2014 or 15, not exactly I don't know. So you can say at the policy level, it was not considered as that it will health department should be included. So, but in the end, climate change is going to affect the health, so it should be included in it. So we already know that the temperature is going to rise if we don't control our this pollution level or not, and the temperature will rise by 1.5 degrees Celsius or 2 degrees Celsius, and the mortality will definitely increase. So the data is saying so at the global level. So we have to be prepared for that. First of all, what we have to do is to create the awareness among the policymaker and create the awareness among the public to control that. And awareness is the first thing that we have to do. Then we have to do the capacity building of the physicians, the pediatricians at the hospital level, and educate the school level, the teacher at the school level, and the sports teacher as well, because the thing is going to rise. And as experts are saying at the physician in the last week we had the webinar that the cases of this cardiovascular increases as an epidemic. It is increasing at the hospital level, the cases of cardiovascular, and that the further their death, they are seeing, they are current right now, they are seeing that thing. So we can say that in future it will be a most important thing that we have to look after, that because it is not only the heat stroke, it is other thing that it is also including it in itself, that the death due to the heat and the cardiovascular disease, that to the respiratory disorders, that to the kidney disorders. So those deaths are also increasing. So death in the geriatric age group, death in the children's, and due to dehydration, those will be increasing, and those are increasing right now as well.
Okay, thank you. And one last question, Dr. Kumar. Here it is. Are you and your colleagues able to track the impact of increased heat on crop loss and the effect of that on the mental health of citizens who rely on crop growing, selling for their livelihoods?
That's a good question. And mental health is always considered in the last whenever we have the health problems. And in the national program as well, the mental health came very late at the national level. And in the national program on climate change, there are 13 climate sensitive disease that we include. And right now we are focusing mainly on the heat related death and the air pollutions related morbidities. But in future as well, we are going to include the mental health as well, because that include itself in it. So yeah, the if mental effect due to the crop burning or not, or due to migration because there is a drought condition, and those things are there. But right now it is in the establishing phase. So I think by next year or next to next year, we can see that we will consider those things in mind, and how to help the poor people at the periphery, remote areas to get out of it.
Thank you very much. And as far as closing comments, back in 1995, when we were asked to go out to the Chicago for the heat wave and to do some investigations, my initial thought was, wow, why don't they just turn on the air conditioners? But when I was in Chicago, I actually went into some of the rooms where people died, and there was an air conditioner there and it was working. But it's much more complicated than just turning on that air conditioner. And as we see, there's a lot of behavior elements involved with that. And people die because of heat, but there's a lot of underlying events that occur that need to be investigated. And one thing we really found out from our investigations was this social isolation was a big factor for those people who died. And many diseases are named after the place that they were found. Infectious diseases, Ebola. So if heat was named after a place, it'll probably be named after Chicago. They had some serious heat waves and deaths, and they've done some tremendous work through the years. And I would say, if you need to reach out to experts and planning, Chicago is one place to reach out to. Unfortunately, they survived several heat waves, and they have this wealth of knowledge and experience. So I'd be reaching out to them if you want more information and details about not only the epi part, but also the social aspects and the public health response to heat waves and preventing heat-related illnesses. So this brings us to an end on our seminar on heat-related illnesses. I want to thank our two speakers, Chris and Dr. Kumar, for their presentations. Very interesting and informative. And thank you, participants, for your questions and your interest. And I'm turning this over to Amber now. Thank you.
Sure. Thank you. And thank you for joining us, Alden, and for sharing your expertise on this topic. I just want to address a couple of quick housekeeping questions that I've gotten in the chat, and then we can go ahead and all say goodbye. So I will be sending out the slides as well as the recordings for the session to all of the attendees here. I will ask our speakers if they're willing to also share their contact information in case anyone has additional questions that we did not have the time to get to today. In addition to that, we do host these webinars the fourth Wednesday of every month. We cover a different topic on climate and health. The next session is scheduled for July 27th at the same time, 8 a.m. to 9:30 Eastern time. We don't yet have a registration link, but we will be setting up that registration link for that session. If you keep an eye on either TEPHINET's social media channels or our two partners, the Global Consortium on Climate and Health Education and the International Association for National Public Health Institutes, we will be sharing the link to register for that next session on our social media channels. But go ahead and mark your calendars if you are interested in joining. That session on July 27th is going to be covering wildfires and air pollution. Thank you all so much for joining today, and I hope you have a wonderful rest of your morning, afternoon, or evening.
Thank you, Amber.
Thank you. Thank you all.
Yeah, thanks so much.